The longer you take pain medications, dopamine is released. These receptors now start to become saturated and they require more medication to trigger more dopamine to get the same amount of pain relieving effects or euphoric effects. I see patients who are taking pain medications every month, but within another 2-3 months, again, the patients will say they need a further increase. Instead of the pain getting better, the pain actually gets amplified and intolerable. Everybody is going to develop tolerance, and very soon they'll understand that tolerance is not something you can escape from.
Welcome back to the Kentucky Pain Reversal Show. In our first episode, Dr. Nair walked us through the pain spiral, how an injury can quietly turn into years of chronic pain through pills, procedures, and missed opportunities for real intervention. Today, we're focusing on one of the most misunderstood parts of the journey, pain medications. Many people listening right now didn't choose pills casually. They followed medical advice, they took their prescriptions exactly as directed, and yet over time, the medications that once helped stopped working or even made things worse. In this episode, Dr. Nair explains why that happens, not from a place of judgment, but from biology. We're going to talk about dopamine, receptors, tolerance, and the difference between dependence and addiction, in plain language for you to understand. So let's dive in. Dr. Nair, last time in episode 1, we talked about how people can get trapped in chronic pain. Today, I want us to focus more on the pills and the solution side. So why is it more important to understand how pain medications actually work in the body?
Well, pain medications can be divided into 2 groups. One would be short-acting pain medications, and the other group would be long-acting ones. The short-acting ones usually have a lifespan of about maybe 4 to 5 hours. The long-acting ones can be anywhere from 8 to 24 hours. Now, you also have medications that are in the form of a patch, like the fentanyl patch. That is placed on the skin, and it will last for about 72 hours. All of these medications, their mechanism of action is that once it binds to the pain receptors, it will reduce the number of nerves that are firing, causing pain. So let's say somebody has chronic foot pain. Well, that pain is going to be there throughout the day, which means that the nerve fibers are firing constantly, telling the patient, hey, I've got pain over there. So when these patients take pain medication, the pain medication acts on the opioid receptors by decreasing the number of nerve impulses or the nerve firings. And that's how the pain gets better. So that's going to be universal with short-acting versus long-acting. So in a nutshell, that is how pain medications work.
That is so interesting. Oh, thank you. I feel like I just learned so much already. Many patients are under the impression that if they're taking pain medications for, quote, real pain, addiction can't or won't happen. Why is that belief medically incorrect?
Well, you're right. That is medically incorrect. These terms can very often be very confusing, such as the terms that you talked about, dependence, tolerance, and addiction. These are 3 very different things. So let's start with how pain medications work. Now, we talked about it reduces the number of nerve impulses that are firing. Well, what also happens is that the narcotic medications will trigger the release of dopamine in the brain. In particular, there's an area called the nucleus accumbens, and that's where the dopamine receptors and the dopamine is released. Now, that is going to give the patient a sense of, well, my pain's not that bad. I'm feeling a little bit better. I'm feeling actually quite a bit better, bordering maybe a little bit of euphoria. All right. So that's where the dopamine receptors come in. Now, the longer you take pain medications, dopamine is released. But what happens is these receptors now start to become saturated and they require more medication to trigger more dopamine to get the same amount of pain relieving effects or euphoric effects. So that is the beginning of tolerance. So in a nutshell, tolerance is when a patient develops the need to have a higher dose of the pain medication to achieve the same amount of pain relief, and it will last longer. So that would be tolerance. So it goes to say that as the patient takes medication for a longer duration of time, there will be a greater development of tolerance. Now, coming to dependence. Dependence, and again, it's a very fine line that separates tolerance and dependence. Now, we know that when the dopamine is released, the patient will have a sense of well-being, sense of reduction in pain, the ability to do more work. But when there's less dopamine that's released, then you're going to have adverse symptoms like jitteriness, a feeling of dysphoria or a lack of interest in things, sometimes even depression, and not to mention an amplification of pain. So these are the beginning of symptoms related to withdrawal from not using the opioids, which in turn would reduce the production of dopamine. So the production of symptoms or adverse symptoms that are associated with reduction in the pain medication consumption would be the beginning of dependence. So the patient is now dependent on medications for pain so that they don't go into early withdrawal effects. And then, of course, finally, you have the word addiction. Now, think of addiction as being supersized version of tolerance or dependence. But the important difference is the person who's addicted to narcotic medications will start having abnormal and aberrant behavior in the pursuit of getting their next dose of the drug. So this might make the patient do certain things that they normally wouldn't do. They may, go into their families or friends' medicine cabinet and they'll be looking for pain medication to consume. They may use fictitious reasons with their healthcare providers to get more pain medication. They may run out of their medications early, or they may do certain activities that we would consider questionable, like going out on the street and purchasing medications, resorting to illegal ways, maybe breaking an entry, going into a drugstore and trying to, steal the medications off the counter. So abnormal behaviors, which they normally wouldn't do, would be the definition of being addicted to a drug. So I think that should clarify these three terms: dependence, tolerance, and addiction.
That was a perfect synopsis of those three, and I think our listeners definitely have a much better understanding of that. I love the way you kind of segmented those there for us. Dr. Nair, can you explain in simple terms what happens in the brain and the nervous system when someone takes opioids over a long period of time? We just talked about the dopamine and receptors, but let's unpack that a little bit more. What role are they playing?
So pain receptors are mainly located in the brain and the spinal cord. Let us say a patient has a disc herniation that turns out to become sciatica, which is essentially the irritation of the nerve root causing severe pain radiating down the leg, can be associated with numbness and tingling. When a patient takes a pain pill like oxycodone or hydrocodone, the drug first needs to dissolve in the stomach acids, and then from that, it gets absorbed into the circulation. Once it's in the bloodstream, it has to go through the liver. Some amount of that drug is going to be metabolized and it's going to go out of your body. The remaining will then continue in the bloodstream and reach the brain and the spinal cord. And that's where those receptors that I was talking about earlier are present. Once the medication combines with the receptors, it is going to do two things. One is it would reduce the number of painful impulses that are fired, and it will reduce the dopamine in the nucleus accumbens in the brain, which is what gives the euphoric, feel good, I don't have that much of pain, and I can do more work feeling. Now, it is important to point out that when patients take medications by mouth, the whole process of dissolving in the stomach acids, it's not a complete process. So there's a percentage of that pill that you've taken that will not be absorbed in the stomach or maybe metabolized in the liver. So the amount of medicine that reaches the brain is a fraction of what was consumed. That also contributes to the whole phenomenon of tolerance. Because even though we may take a 10 milligram pill, it might end up being about 5 or 6 milligrams when it reaches the brain. So we may think, okay, 10 milligrams is being consumed, but in effect, it's a much lower dose, and that contributes to tolerance.
Okay, so if I'm taking a 10 milligram pill, that might actually only be, like you say, 5 or 6, and then we keep upping that dose there. That's really, I've never thought of it that way. So why do pain medications that once worked so well slowly stop working, even when patients are following the prescriptions and directions from the doctor just exactly how they're supposed to?
And I have so many patients who follow doctor's instructions. They take their medications, they'll be watching their clock. Even though they may be only allowed to take 4 pills in a day, they'll be taking it 24 hours divided by 4. So every 6 hours, they'll be watching their clock to take their next pill. Now, what happens is that as a patient continues to take pain medication, the receptors, the pain receptors that we were talking about, they now develop a higher threshold, which in layman's term, it requires a greater amount or a larger milligram of the medication to fire, to trigger the receptor. And so as time goes on, you need a higher amount of medication to trigger the same response, which would be reduction in pain, and it needs to be able to last as long. One other aspect that a lot of physicians are not very clued into is that different human beings have different rates of metabolism. As you know, metabolism occurs in the liver, and that is based on the blood flow to the liver. And that can vary in individuals, and it can vary in the same individual throughout the day. So sometimes if you're taking the medication at a particular time of day, and if it is metabolized faster, then the available drug decreases. And hence, a lot of times patients will say that they have waxing and waning of their pain after taking a pain pill. It's not a constant level of pain relief. And this is part of the reason why.
Again, so interesting. At what point does that dose escalation become a warning sign, not per se of addiction, but of a system that's no longer treating the pain correctly? When do you start saying, okay, this is not the right treatment anymore?
Well, in my experience, I see patients who are taking pain medications every month for 3 or 4 months. They'll start saying, hey, doc, this dose is not working for me. It's not lasting long enough. And then I would incrementally increase it. But within another 2-3 months, again, the patients will say they need a further increase. Of course, that would occur up until the patients get a little bit of pushback saying that, okay, we can't increase the drug beyond a certain amount. So that's what I've seen. And, you know, it's quite consistent. Patients kind of develop the tolerance within about maybe 2 or 3 months.
That's pretty quick.
It is. And it's alarming too.
Wow. Okay. Well, so in your experience, how does perhaps longer or long-term oral opioids use actually worsen the pain over time? Is that a thing? It can make it worse?
You know, that is a great question. There is an entity known as opioid-induced hyperalgesia. Now, this occurs when the doctors start incrementally increasing the dose. And what they'll see is instead of the pain getting better, the pain actually gets amplified and intolerable. This is essentially, it's a wind-up mechanism that occurs at the receptor level. It doesn't happen very often, but it does occur, especially if patients are taking larger doses of long-acting opioids like OxyContin or MS-Contin. I've also seen that in the fentanyl patch, that patients develop opioid-induced hyperalgesia. And usually the remedy is first to be able to identify it, and you can either rotate and use a different opioid or a different class of medication that acts on a different pain receptor. So those are the ways to treat opioid-induced hyperalgesia. But I guess the bigger thing is, how often are healthcare providers and patients able to identify this entity?
You are specifically board certified in addiction medicine. What do most people and even many physicians misunderstand about dependence versus addiction? I know we talked a little bit about it earlier, but what's the biggest misconception about dependence versus addiction?
Well, in my opinion, what I've seen is that most doctors recognize tolerance and they treat tolerance by increasing the dose or increasing the frequency. But as I told you earlier on, that may not be the remedy, or it may be a short-acting remedy. It might work for a certain period of time. Some doctors may resort to using a longer-acting opioid like MS-Contin, OxyContin, or even long-acting preparations for Dilaudid. But they can also see the same phenomenon like opioid-induced hyperalgesia. Now, at some point when these physicians feel uncomfortable in prescribing these higher doses of medication, what they may do is they may recommend the use of drugs like Suboxone or other drugs that may be used to treat opioid use disorder. Because now a patient who's had chronic pain will be designated as somebody who has an opioid use disorder, which is now, it's shifting from a pain management realm into an addiction realm. The unfortunate thing is, even with drugs like buprenorphine or Vivitrol, the issue is that that drug also you can develop tolerance to it. So it's just a never-ending spiral. I feel that in these type of situations, it's important to identify patients who are rapidly developing tolerance and to educate the patient as to what they're experiencing, and also to be aware that there may be other ways to treat pain, other ways to deliver the opioids. And I'd mentioned earlier that there are certain things called an intrathecal pain pump, which is a device that will deliver pain medication directly into the spinal fluid, which is in contact with those receptors we talked about earlier on in the brain and the spinal cord. So those patients who do have pain with escalating need of oral opioids, they may be patients to be considered for a pain pump.
And it seems like that because we're bypassing kind of the journey that the pill has to go on through the stomach, through the liver, its potency might be able to, remain the same instead of having to go through different channels in order to get to the brain and the spinal fluid.
That is correct.
Given everything that you've seen specifically in Kentucky, why do pills still remain the default approach, even though we know that they're not a long-term solution?
Well, I believe that the opioid crisis is occurring in every state in America. Kentucky is afflicted with this problem more than other states, partly because, lack of knowledge of other treatment options. But Kentucky has many counties that are in rural areas. And being in a rural area, you may not have access to specialist care. So I feel that that's part of the reason why the opioid epidemic is more in rural areas in Kentucky and in other states.
That makes a lot of sense. For our listeners who are currently relying on pain medications or feel scared or stuck, what do you want them to understand right now before we talk about alternatives in upcoming episodes?
Well, I think there's nothing better than educating yourself. And with the internet, there's a lot of information available, and you have to be selective. But the information online will tell you about tolerance. It will explain in very simple terms what tolerance is. And very soon they'll understand that tolerance is not something you can escape from. Everybody is going to develop tolerance if they're going to take any drug that will release that dopamine in the brain. This applies not just to opioids, it applies to various other drugs, benzodiazepines, Valium, Ambien, alcohol, street drugs. The main thing to remember, it is the release of dopamine. So tolerance is going to occur. Now, specifically with patients who have chronic pain, this is when looking at alternate methods of treatment would be beneficial. As I've mentioned, things like a spinal cord stimulator, using electrical energy, pain can be treated, or using a pain pump. Medications for pain can be delivered directly into these receptors, or even certain types of injections that can block the pain. There are other topical agents. Let's say if somebody has chronic knee pain due to osteoarthritis, simple remedies like over-the-counter anti-inflammatories, Tylenol. Of course, if there are no contraindications for those drugs, can be used. Or you can have the same type of anti-inflammatories that can be administered topically, which are also available over the counter. So these are some alternatives that patients can look at if they fear that they may be getting dependent on their medication. And of course, there are plenty of doctors like myself all around the country, and it may be even worthwhile to call their office and say that they want to have a consultation and to see what the doctor is offering. And then they get their chance to, write what they've learned on a piece of paper and decide what would be the best thing for themselves.
Fantastic. Thank you so much, Dr. Nair. So interesting, so enlightening, and it's so important for our listeners to do their research and get educated. And we're so thankful that you've been able to inform us this way. So thank you all for joining us for episode 2 of the Kentucky Pain Reversal Show. Today's conversation makes one thing very clear. When pain medications lose their effectiveness, it's not a personal failure, like Dr. Nair just said. It's inevitable, and it happens with everyone, and it's simple physiology. Understanding that truth can be incredibly freeing. If today's episode resonated with you, consider sharing it with someone who may be struggling silently. Understanding is often the first step toward change. Lower the pills, lower the surgeries, stop the pain. We'll see you next time on episode 3.